Hello, let's discuss pheochromocytomas, tumors of the adrenal medulla that put a lot of catecholamines into the blood. Easy symptom diagnosis, you confirm it with urine VMAs, which are breakdown products of catecholamines. Also in this SDL, we're going to talk about paragangliomas, which are essentially pheos that are outside of the adrenal medulla. We will also discuss hereditary syndromes that predispose one to pheos. There's neurofibromatosis 1, there's von Hippel-Lindau, there's multiple endocrine neoplasia 2. So I expect a question on that. And then finally, we'll discuss neuroblastomas, which are in this SDL because they frequently do secrete catecholamines. So I expect one question on the neuroblastoma as well. The adrenal medulla is essentially a bundle of postsynaptic neurons, the presynaptic neurons being sympathetic nerves from the sympathetic chain. And whenever these neurons within the adrenal medulla are stimulated, they're not really neurons, they're chromaffin cells, but whenever they are stimulated, they depolarize and calcium floods into the cell. And so all of the epinephrine and norepinephrine that these cells of the adrenal medulla constantly make will be released and exocytosed all at once in response to that calcium influx. Here is the pathway showing you synthesis of epinephrine and norepinephrine from the precursor dopamine, synthesis of dopamine from levodopa, synthesis of L-dopa from tyrosine. So a couple of big points. Right down here, after all of these amine hormones get metabolized for excretion, because that's why we would metabolize them, to get rid of them from the bloodstream, they turn into metanephrines and vanillomandelic acid, that's VMA, and homovanillic acid. And so these are what we look for in the urine. They're very sensitive, very specific for confirming the presence of a pheochromocytoma. This tyrosine hydroxylase enzyme that takes tyrosine to dopa is the rate limiting enzyme. A couple other things to point out. Tyrosine is a non-essential amino acid, but if you have phenylketonuria, tyrosine becomes an essential amino acid because tyrosine is produced by the enzyme phenylalanine hydroxylase. One more thing I want to say. This dopamine beta hydroxylase enzyme here, this dude that takes dopamine to norepinephrine, requires a copper cofactor. And so if you don't have this enzyme, you have a problem using dopamine properly. So this accounts for why patients with Wilson disease, which is copper deficiency due to problems getting it into the bloodstream and transporting it. Patients with Wilson disease present with Parkinsonism symptoms. What's our frontline treatment for Parkinson disease? Levodopa. So it should make sense to you that the same motor symptoms that you see in Parkinson's disease due to a dopamine deficiency, you can also see if you have a copper deficiency that prevents you from using dopamine properly in the brain. Your chromaffin cells of the adrenal medulla are always making epinephrine, norepinephrine, and they will release it whenever they're sympathetically activated. So anything that ramps up your sympathetics, whether it's you wake up and you have an exam in 20 minutes, need to get dressed, or a heart attack, anything at all that's going to activate you is going to push epinephrine into the bloodstream. And so that process, again, is initiated by acetylcholine release from preganglionic sympathetic fibers. And it'll bind to nicotinic cholinergic receptors, causing depolarization of those chromaffin cells that leads to calcium influx, which will spit out epinephrine from where they're stored inside intracellular vesicles. Epinephrine has a short half-life. It's quickly degraded through those COMT and MAO enzymes into metanephrines, which we will screen for in the urine to confirm the presence of a pheochromocytoma. Now, a pheo is a tumor arising from chromaffin cells of the adrenal medulla, and chromaffin cells make epinephrine and norepinephrine. You don't just have chromaffin cells in the adrenal medulla, you also have them elsewhere in the sympathetic nervous system because norepinephrine is a sympathetic neurotransmitter. So you might see a tumor arising from chromaffin cells elsewhere in the body besides the adrenal glands, and if you do, you would call that a paraganglioma. Paragangliomas and pheos have similar presentations and are treated with similar approaches. It's all about location for diagnosing the two of them. For pheochromocytomas, they tend to present in adults between the 3rd and 5th decades of life, and 10% of them occur in children. We have a rule of 10s for pheochromocytomas, handy to know, similar to our rule of 2s. Do you remember what pathology has a rule of 2s? That would be Meckel's diverticulum. So the rule of 10s for pheochromocytomas, 10% of them are malignant, 10% are bilateral, 10% of them occur outside the adrenals, 10% of them calcify, and finally 10% of them are pediatric in origin. We also have 5 Ps. These are pretty useful. First aid comes through sometimes. Our symptoms here for pheochromocytoma, which also starts with a P, you get pressure, blood pressure because of the alpha-1, beta-1 activity. You get pain due to the high blood pressure. You get perspiration and sweating. You're sympathetically activated, and so your sweat glands respond to that. You get palpitations, that's your beta-1 activity again, and you get pallor because you are going to be peripherally vasoconstricted. Not a lot of blood will be going out to your skin whenever you have a high blood concentration of epinephrine, and so that's going to be visible. So the symptoms make sense. What do these things look like under a microscope? Crowded cells, pretty basophilic nuclei, speckled appearance. If you zoom in on them, that's because of the chromaffin granules containing these catecholamines. You can immunostain them for various things, such as chromogranin-A, synaptophysin, neuron-specific enolase, bombesin, all of those neuronal neuroendocrine tumor markers, they will pick up on a stain. And electron microscopy might be thrown at you as well, or you might get asked, what would you see on EM? And that's an easy answer. You see a lot of granules containing catecholamines ready to be secreted at a moment's notice. Now, because the symptomatology of catecholamine secreting tumors is so particular, this really is not a histological diagnosis. So don't be fretting if you can't tell the pheo apart from the normal cells of the adrenal medulla. It'll be made obvious to you on an exam question. Genetics, pretty important section here. Don't skip over it. Don't blink. You'll miss it. Pheos are highly associated with von Hippel-Lindau. Mutations in that VHL protein lead to an inability to ubiquinate and degrade this other protein called HIF-1A, and that's hypoxia-inducible factor. And so if you're not getting rid of HIF-1A, that means that your cells are constantly in the midst of a stress response to hypoxia. So what do cells do in response to hypoxia? Well, they release a lot of endothelial growth factors that promote angiogenesis and VEGF as well. And so that just makes it easier and easier for a tumor to grow. RET oncogene mutations, gain of function mutations, also common. That's a tyrosine kinase. And where else do we see RET mutated? We see it in the medullary thyroid carcinoma in association with multiple endocrine neoplasia 2A and 2B. And finally, succinate dehydrogenase might also be mutated in sporadic pheochromocytomas. So even though these are mutations in familial genes, these are still the genes that tend to be mutated in sporadic pheochromocytomas. Going back to discuss the presentation of a pheo, the symptoms make sense: high blood pressure, tachycardia, sweating and pallor, headache because of that intracranial hypertension. Understand that this is a disease that presents in an episodic nature. It's here and then it's gone, and then it's here and then it's gone. So typically patients will have these attacks, and then maybe if they're, like you or me, they might not go to the doctor initially, but then they'll have one big bad attack, and then there they are in the emergency room. Catecholamines in excess also damage the heart. Your heart doesn't want to be on all the time. It wants to calm down and rest. Your heart likes to kind of sleep too, like we do, even though it doesn't sleep like we do. So because it always has the heart ramped up, a pheochromocytoma does, due to all these catecholamines, you might just start to see some overuse injury to the heart, which will present initially as contraction band necrosis. Your immune system comes in to sweep all that damage up, and it leads to myocardial fibrosis. And there's a litany of cardiac complications besides that: MIs, arrhythmias, ischemic heart disease. Catecholamines are vasoconstrictors, and Your coronary arteries don't like that, you dig? Hypertrophy, absolutely overuse right there, you know, left ventricular hypertrophy for days. So a lot of different things that can happen to the heart. When you're differentiating a pheo from anything else, you want to think about other disorders that may present with similarly episodic symptoms, such as carcinoid syndrome, in which a tumor is making a lot of product and it'll put it out into the blood in spurts. Also have to have a variety of hypertensive diagnoses on your list because these patients will present with a high blood pressure. So how do we pick it up? Urine metanephrines is 98 sensitive and specific. Very good test. Another one you might run is plasma chromogranin A, which is 83% sensitive, meaning there's not many false negatives. And one last thing they might ask you about pheochromocytomas is the pharmacology of how you approach them preoperatively. You have to give phenoxybenzamine before you give a beta blocker. Obviously, you really want to give a beta blocker so that you can lower this patient's blood pressure, but you need to give an alpha antagonist first. Otherwise, that beta blocker, patient has a lot of catecholamines in the blood. So if you block beta 1 and beta 2 receptors, then alpha 1 activity is just going to ramp up. And so what that means is that their peripheral vasculature is just going to clamp, you know, and that's really bad for the heart because it's trying to push blood outwards and it can't push blood out through a pinhole, you know. So that's the pheochromocytoma. Fairly easy symptomatic diagnosis here. The paraganglioma is essentially a pheochromocytoma that arises elsewhere in the body besides the adrenal glands. And these things look exactly the same under a microscope, which is why I say the histology is not of the utmost importance here. Paragangliomas, also like pheochromocytomas, tend to present in mid-adulthood. So they can pop up along the parasympathetic or the sympathetic chain, and it makes sense that sympathetic paragangliomas are going to produce a lot of norepinephrine, and parasympathetic paragangliomas will not. So parasympathetic paragangliomas tend to present simply with mass effect depending on where they are growing in the body. And that's not something you really memorize. That's just something you kind of work backwards from when they give it to you in a question stim. Patient has hoarseness. Oh, it's up here, you know, like patient has ocular manifestations. Well, it's up here. Patient can't hear. Maybe it's in the ear, you know, stuff like that. Here's a good chart showing you all the different regions in the body you can get a paraganglioma. You know that your vagus nerve is going to run down along the carotid on both sides. And your sympathetic chain is para-aortic bilaterally as well. And then you have a few ganglia sitting right next to your 3 big GI arteries here. And this inferior most sympathetic ganglia is also called the organ of Zuckerkandl, which pops up a couple of times in this SDL. So this is where it is. It's the ganglia right next to the inferior mesenteric artery. The most common paraganglioma of the head and neck is the one that arises at the carotid body, which is the bifurcation of your common carotid into the internal and external. And remember, you have baroreceptors and chemoreceptors there. And those chemoreceptors are particularly called glomus cells that sense the partial pressure of oxygen in the blood and will initiate a sympathetic response accordingly. You can get paragangliomas, however, anywhere down the vagal chain, even in the skull, the middle ear, the tympanic nerves. Thoracic, abdominal paragangliomas, again, don't memorize it. They'll give you the symptoms. It'll be easy. Imaging, they don't want to ask you about that, I don't think. And surgery, obviously. I mean, it's like you're not going to treat this with Advil. So that's a paraganglioma. Now we get to syndromic pheochromocytomas, not sporadic, but familial in nature. Associations with 3 diseases, von Hippel-Lindau, neurofibromatosis type 1, and multiple endocrine neoplasia type 2. So got some first aid stuff. We'll pull that up and look at it. Here's a pheochromocytoma. They're always encapsulated, never invasive really. Top left of this picture is the pheochromocytoma. Notice how these cells are darker and smushed together really compared to adrenal cortex in the bottom right. And these are cells of medullary origin again. Here's a slide on von Hippel-Lindau disease. You can remember the associations with the mnemonic HARP. You get hemangioblastomas, angiomatoses, renal cell carcinomas, and pheochromocytomas. So because this hypoxia-inducible factor, if you have a lot of it, you get a lot of VEGF, you get a lot of endothelial growth factor. That explains the hemangioblastomas, blood vessel tumors, and angiomatoses as well. Multiple endocrine neoplasia. We got 3 Ps, 2 Ps, and 1 P. And one of the Ps for MEN2A and 2B is the pheochromocytoma. So because of the RET oncogene, you will also have medullary thyroid carcinoma. With MEN2A, you get some parathyroid problems. So you're going to have some blood calcium imbalances. And with MEN2B, you tend to see mucosal neuromas. Those are benign little nerve sheath tumors that pop up on mucosal surfaces, such as on the inside of the mouth, on the tongues, or maybe you encounter a handful of little bumps upon GI endoscopy. Finally, NF1. The gene NF1 is going to code for the neurofibromin protein. Love it whenever it's that simple. This has 100% penetrance, which means that everybody with the gene will eventually show the phenotype. Everybody with the mutation, I should say. Characteristic symptoms include these cafe au lait spots, areas of hyperpigmentation, small little bumps, cutaneous neurofibromatoses, and then these Lisch nodules, which are hamartomas of the iris. And a hamartoma is kind of like a tumor in that it's an abnormal growth, but it's really not a hyperproliferation of cells. It's more so a abnormal architecture of cells. They don't look normal. There's not a lot of them. They just don't look normal. Then the SDL discusses familial paraganglioma syndromes. These cases are 1 in a few 100,000 people, and I have not been able to find anything about paraganglioma in first aid, pathoma, AMBOSS, med bullets. So you learn this however you want to for our exam, but this is step 2 stuff. This is pathology residency stuff. The thing I'm going to take away is that a couple of these present with single paragangliomas, type 3 and type 4, and then a couple of these present with multiple paragangliomas. So that's your first step in your differential chain. And then the second step is just remembering the genes really and correlating them to the locations. So type 3 presents with single paragangliomas of the head and neck. And I'm going to remember type 3 because that's the SDHC gene, and C is the 3rd letter of the alphabet. So that's a good point of reference to anchor into your memory what's going on here with these 4 different types of paraganglioma syndrome. Now, type 4 and type 1 do not follow that alphabetical order rule. They made type 1 SDHD gene, and then type 4 is the SDHB gene. So I wish it was just A, B, C, D for the 1, 2, 3, 4, but that would be too easy for us medical students, you know. So you memorize this if you want to. I won't dwell on it. Now, peripheral neuroblastic tumors. This is a big deal. You might see neuroblastoma on boards because there's a big differential with Wilms tumor. They both present as pediatric abdominal masses. So what you see when you biopsy this thing is you see Homer-right rosettes, letting you know it's of neuroendocrine origin. And you also see small round blue cells, letting you further know that it's of neuroendocrine origin. So the small round blue cells actually doesn't just tell you it's neuroendocrine. It tells you it's a blastoma, which is a stem cell tumor, essentially. It's a tumor of cells that have yet to differentiate. So another blastoma that we've seen is the medulloblastoma, which also presents with rosettes and small round blue cells. So a large part of making this diagnosis is recognizing the characteristic histology right off the bat, and also recognizing the different immunohistochemical stains that we can use to drop on these slides to tell that it's a blastoma or and a neuroendocrine tumor, things like NSE, bombesin, and chromogranin A. So peripheral neuroblastic tumors pop up from primordial neural crest cells that have yet to differentiate into components of the sympathetic nervous system. And because these dudes are stem cell tumors, of course they have the capacity to synthesize and secrete catecholamines. Nobody's ever told them not to, you know? Again, the differential is Wilms tumor. Neuroblastoma is actually more common. It's the third most common childhood cancer, and it is also the third most common cause of childhood cancer mortality. So the incidence peaks in infancy, and by age 5 or 6, you really don't see these things anymore. You're going to catch them very, very early on in life. Now, the adrenal gland is the most common primary site, but the majority of neuroblastomas are not adrenal. Only 40% of them come from the adrenal glands. And so that organ of Zuckerkandl that's right next to the inferior mesenteric artery, that's a popular place for a neuroblastoma to pop up. But it really can be anywhere along the sympathetic chain. You might rarely see them in the cervical region or lower in the pelvic region. Now, the pathology is important here in as much that it is just going to give this diagnosis away very early on in the question stem for you so that you can focus your intentions on remembering whatever they're asking you. Small round blue cell tumor, Homer Wright rosettes. Now, what's a Homer Wright rosette? It's this rosette that doesn't have a core. It's empty in the middle, kind of like a donut hole. And we compare this to the Flexner-Winterstein rosettes, which are from some cancer that I cannot remember right now, you know, like I'll see you in boards prep, but I do remember that Flexner-Winterstein rosette would have a little neuropil core in the middle of it, which the Homer Wright pseudo-rosette lacks, and so that's why it's called a pseudo-rosette. So small round blue cells, again, lets you know this is a baby tumor, this is a stem cell tumor. And talking about neuroblastoma specifically, what they really want to ask you is about this MYC in oncogene. So you get a gain of function, you get an amplification of this gene. And the gene causes stem cells to proliferate and divide. And so if you have a gain of function, you get more stem cell proliferation, hence the tumor. Really, neuroblastoma is the tumor to focus on here. We also have the ganglioneuroblastom, which is characterized by an increased proportion of Schwann cells within the tumor. And then we have the ganglioneuroma, but that one is really low yield. It's got a predominant Schwann cell component. They really don't want to ask you about those last two. They want to ask you about the neuroblastoma typically. So you should understand what you see on histology now. Let's get into the genetics a little bit more. Familial neuroblastoma tends to be because of this ALK gene, anaplastic lymphoma kinase. So contrast that to sporadic neuroblastomas, which tend to be due to, number one, MYC in MYC, however you want to spin that. That's the one that's in all the board review books. But also this gene called TRAC, tropomyosin receptor kinase A or B. And so whether they have a TRAC A or a TRAC B subtype kind of matters in the handling of these tumors, because tumors with TRAC A have much more favorable prognoses than tumors with TRAC B. And that's because if you have this TRAC A, you are way more responsive to the surrounding environment and the presence of, what's it called here? NGF, that is neurotrophic growth factor, nerve growth factor. So if you have this TRAC A, you're responsive to nerve growth factor. And nerve growth factor, if it's not in the environment, well, the tumor just dies. So great, tumor goes away. But if you do have neuron growth factor in the environment, the tumor will differentiate, which is not the best outcome, but at least it'll stop dividing, because a differentiated neuron really is not going to be able to split itself up anymore, you know. So both of those outcomes with the TRAC A subtype are favorable. And so we're going to call that the subtype 1 of sporadic peripheral neuroblastomas. Subtype 2A, 2B, no such favorability. They're associated with an older age, worse outcomes, and aggressive malignant tumors. Here at the bottom of 13, I've summarized the genetic changes of the sporadic PNTs. Type 1 has that track A, type 2 has track B, and then you also tend to see this thing called brain-derived growth factor. Just a lot of memorization there. Understand also that you're going to see deletions in chromosome 1, maybe chromosome 3 or 11 with neuroblastomas as well. But this MYCN oncogene is really where it's at. Again, that's what all the review books say. Understand it is an oncogene, so you're going to get a gain of function leading to neural stem cell proliferation. And the more MYCN that these things express, the more aggressive these tumors are going to be. So making the diagnosis, how does a neuroblastoma present? Large palpable abdominal mass, tends to cross the midline, which Wilms tumors do not. Those tend to be unilateral, and those are renal tumors. And so Wilms tumors also have nowhere near the degree of systemic involvement that neuroblastoma does. Things like fever and weight loss there due to metabolites secreted by this large tumor. Symptoms also can be related to the mass effect of the tumor depending on where it's at. You might see constipation, you might see enuresis, trouble passing urine. If it's farther up, more towards the head or neck, you might see some respiratory problems or caval compression, possibly leading to hypotension there, and ascites elsewhere in the abdomen, maybe ascites in the upper limb if it's the superior vena cava. Horner syndrome, you know that's compression of the sympathetic chain, leading to sympathetic overactivity within the head. Tends to be unilateral. And finally, these neuroblastomas do produce catecholamines, and so all the symptoms of pheochromocytomas may apply here. The last real thing I want to focus on are the two paraneoplastic syndromes you see with a neuroblastoma. It could potentially secrete a lot of vasoactive intestinal peptide, which is going to lead to diarrhea because it's going to upregulate electrolyte channels on the luminal surface of the gut. And it's also going to relax the smooth muscle of the gut. And so whenever you contract the gut, you keep food that you ate in one place and you allow it to be digested. But if it's relaxed, then food just goes straight through like a subway through a tunnel. So hence the diarrhea and hence the potential electrolyte imbalances. And the really characteristic paraneoplastic syndrome here is called OMAS, opus clonus myoclonus ataxia syndrome. And we've seen this in one other cancer. We've seen it potentially in small cell carcinoma of the lung, which is also a neuroendocrine tumor. So OMAS presents with what they call dancing eyes and dancing feet. You're going to have jerky eyes that kind of just spontaneously go everywhere, you know, shifty in nature. And you're also going to get myoclonic jerks of your extremities, so your wrists, your feet, your knees, your elbows, you know, and as well as that, irritability and sleep disturbances. And this OMAS syndrome is caused by autoantibodies against particular autoantigens, including cerebellar cells, hence the ataxia, and also Purkinje fibers. What are those? That's the ventricular conduction system of the heart. Now, you can diagnose many neuroblastomas based off of urinary metanephrines, VMA, HVA, those breakdown products of catecholamines. These things also do calcify, and so that'll be another clue if you're shown an X-ray or CT. And finally, the course of this disease is very unpredictable. It does kind of go back to the genetics. If it has track A, favorable prognosis because it can spontaneously go away or spontaneously differentiate, at which point it's going to really slow down its rate of growth, versus the track B, which is not going to differentiate, not going to go away. It's going to stay in the stem cell stage forever and just keep growing and growing and growing until you cut the thing out. Last slide that I have, here's a neuroblastoma. Look at how big this thing can get. And so, of course, palpable abdominal mass, symptom number one. And I wanted to draw your attention to a potential metastatic site for this neuroblastoma. It has a predisposition to going to the orbital socket. And if it gets in there, then it can cause a mass effect on the veins of the skull that are draining that facial and ocular region. And so you might start to see kind of raccoon eyes is what they're called, periorbital ecchymosis or bruising. And so that's indicative that this tumor has metastasized up and lodged itself inside the skull. That's about all we got. Pheos are really straightforward. Understand the genes, Thankfully, there's not a lot of overlap in genes between the pheochromocytoma and the neuroblastoma. There's none at all, actually. So just check your boxes. You'll be good.